So back to our patient, who's a 64-year-old man with stage 4G junction adenocarcinoma, radiographic and biopsy-proven metastatic disease in the liver. So you ordered all the necessary biomarker testing, including HER2, MMR, and PD-L1, as well as NGS, which is already is ordered and pending. So the patient comes back to you in clinic, he had a Metaport placed, and you find out that his tumor is found to have HER2 overexpression, IHC3+. At this point, since immunohistochemistry is high level overexpressed, you do not need to do FISH testing, and you can proceed to first-line HER2-directed therapy. What is interesting and important is that we understand now that co-occurring alterations within HER2, because G-junction tumors are chromosomally unstable, they harbor other alterations, often in addition to HER2. And those matter when you're trying to predict how long is the patient going to benefit from first-line therapy. So what's interesting, you got the NGS back later, maybe 2 or 3 months after initial presentation, and the patient is doing well. But lo and behold, you find that the patient has co-occurring P53 mutation, which is very common, and also KRAS amplification and a MYC amplification. Those are known to be negative predictors of durable benefit from HER2 inhibition. What is good that on NGS, the patient had high level of HER2 amplification, which is also a favorable factor. We found that high level of HER2 amplification in the top quartile by NGS typically is more favorable outcome on first-line therapy. For this patient, he would receive standard of care, pembrolizumab plus trastuzumab and chemotherapy, which is typically either 5-FU or capecitabine in combination with oxaliplatin. That has been FDA approved based on interim analysis of KEYNOTE-811 data. And the patient did very well for a long time. The liver lesion went away. The primary tumor really had a great response. Unfortunately, after approximately 16 months on therapy, the patient started to develop radiographic evidence of disease progression. So what do we know about HER2 in second line? Well, we know that most patients continue to benefit from HER2-directed therapy, and this has been validated by trastuzumab deruxtecan antibody-drug conjugate second and third line studies, both DESTINY-Gastric-01 and DESTINY-Gastric-02. But we also know that up to 20 to 30% of tumors lose HER2 as a target after progression on first-line HER2-directed therapy. So for our patient who's coming in now with bulky retroperitoneal lymph nodes, so different site of disease, it will be very important to get either a liquid biopsy using circulating tumor DNA or tumor biopsy through radiographic biopsy to confirm HER2 status before deciding of what to do in second or third line therapy. If the tumor is HER2 positive, or if there's evidence of circulating tumor DNA positivity for HER2, the patient is eligible to receive trastuzumab deruxtecan in second line setting.